acid reflux is also a very common problem and it is related to obesity. So I'm going to talk to you about acid reflux as well because we do now have some endoscopic options in which we can treat acid reflux without surgery. So that's what I'm going to tell you about. So this is the scope. What we do is inside your stomach and we're looking backwards at the esophagus, or what we call the GE junction is. So it's a condition in which you have reflux from acid and contents of the stomach into the esophagus, which results in symptoms of heartburn or regurgitation and can result in complications as well. It is also very common. Up to 20% of the population in the US has GERD at least twice a week, and up to 40% have GERD at least once a week. So a lot of people, I assume many of you, I know, have had acid reflux, and you know what that feels like. Some degree of acid reflux is normal, but most of it we have mechanisms. Our esophagus has mechanisms to clear acid reflux, so that doesn't cause problems. When it causes problems, it becomes symptomatic. Then that's the issue. But is it also very costly? Everything I'm talking to you about today is very costly. In the US, $134 million every year are spent on over-the-counter medications for acid reflux. It's very like Prozac, omeprazole, Maxine, things like that. And it is API, which is this class of medication. It's one of the most commonly prescribed medication in the country, or any medication. So most patients, what we call acid reflux, have two primary presentations. One is heartburn, which is a burning sensation in the chest, and it's mild if it happened once a week or less. And we consider it moderate to severe if you've had this more than twice a week on an ongoing basis. Some people don't have this burning sensation in the chest, but rather they have regurgitation. So regurgitation is when you feel that something is coming up from your stomach and is coming into your mouth and throat. It's not necessarily throwing up, but you feel something is coming. And that can happen maybe when you lay down, maybe when you go to sleep, maybe when you pick something up, or after you eat. And usually, like I said, for seconds. But there are some atypical presentations, besides the heartburn and regurgitation. Some people can have chronic cough, chronic hoarseness, worsening asthma, exercise-induced problems, hypersalivation, things like that. So there's a lot of lung issues that can happen as well in patients with acid reflux. So some people may not feel those typical symptoms, but they have hoarseness and they go to see ENT, and you know it's the phone problems. It's going down this acid reflux. So there are some atypical presentations. So again, going back to this picture, this is the fundus of the stomach that we were talking about, okay, on the left side. And this area is called the greater curvature. This is called the lesser curvature. And there's a flap valve, which is a valve that's supposed to be that when your greater curvature distends, you eat more food, it's supposed to push on your esophagus. So it's part of the mechanism to close acid reflux, which is why I'm talking about when you have an laparoscopic sleeve and they get rid of this, you don't have that mechanism anymore. So, what are some of the risk factors for acid reflux? Obesity, we already talked about obesity. Increase in the abdominal pressure, increases relaxation of the esophagus. About patients who have something called the hiatal hernia, and many of you, if you've had endoscopy, you may have been told that you have this. So basically, you have your diaphragm that separates your chest from your abdomen, right? And then the crowded fluid getting to your abdomen, it has to put control in the diaphragm. It's called the hiatus. And it comes to the esophagus. Now that hiatus is like an opening like this. And the hiatus gets bigger. It's just your stomach is going in. Sometimes your stomach starts going back up into the chest. That's called the hiatal hernias. And that's a risk factor for developing acid reflux. Most patients who have very severe acid reflux, a lot of them have this hiatal hernia. So again, you can see in this picture that I took that when we're looking at this work. So you're looking here, there's a gap between, this is the esophagus here, And this is the diaphragm. This is what the diaphragm is. You cannot see the diaphragm, but that's the opening of the diaphragm. And you can see that there's an opening in here, and that's part of the stomach sticking into the chest. This is a small eye. Sometimes we get how far half of the stomach. The stomach is sticking out. You have to have surgery. This is what I was talking about, and I published this uh, before in one of our studies, basically showing that in this diagram, you see that if you have the laparoscopic sleeve where the fundus is cut, you don't have that mechanism of expansion of this area when you eat. And the food will just come up and reflux will come up and you develop something called Barrett's esophagus. So we published this data and we showed that patients with laparoscopic sleeve who had, it's not my sleeve, the surgical sleeve, who had endoscopy before and then had endoscopy and follow-up after the procedure, and about 11% of them developed Barrett's esophagus, which is a precancerous, which is a very high rate, because a lot of these patients have procedures are younger patients that are not supposed to have Barrett's esophagus. So how do we diagnose? Maybe you have the classic symptoms, heartburn, if I eat something spicy, if I eat pizza, if I eat tomato sauce, if I drink orange juice, I get this burning sensation. So that's diagnostic. Usually happens in there are various supports. So you come to see us in clinic. We might ask you a bunch of questions to have kind of assess if you have a reflux. And regurgitation, as we'll ask when you feel like things are coming up from your stomach into your throat. If we give you a medication, try it, then those symptoms go away and say, exhale or something. And you're feeling better, that's also suggestive that that's the problem. But if you don't respond to these medications, there are different things that we can do. But one of them, your doctor might refer you to a gastroenterologist like myself to take a look and see, what's going on. So when we do the endoscopy, you might find that you have something called erosive esophagitis. So basically, when the acid comes up, we can see sometimes damage in the esophagus at the time of endoscopy. So that's called erosive esophagitis. You don't have to have it. A lot of patients who have acid reflux don't have erosive esophagitis because your body heals well. But if you have it, it is a confirmation that you've got reflux. We can also do something called pH testing. So this is one of the ways we do it. Today I did 4 of these before I came here. So we do endoscopy. And at the time of endoscopy, we need a small capsule. It's like an inch size. We leave that attached to your esophagus. And then you go home with this device here. And this capsule will transmit wirelessly to us how much time are you spending in acid reflux. It detects something called pH. It tells someone what is the pH of your esophagus. And we do that for 4 days. And after 4 days, the capsule attaches to your esophagus and goes into the stool, and then you return this device to us. And we use that to confirm if you have acid reflux or not. So when should you have an endoscopy if somebody has acid reflux? If they have no onset abdominal pain, along with this burning sensation and they're more than 50 years of age, if they have evidence that they have bleeding, they're throwing up clots, they have bad stool, they have blood in the stool, if they have iron deficiency anemia, so your doctor does a blood test and they find that you're anemic, they think you have iron deficiency. If somebody's losing weight, they cannot know why. If they have difficulty swallowing at this stage, maybe they drink something or they eat something that gets stuck. Those are all indications that we need to take a look. Or if you swallow, there's a lot of pain, persistent vomiting. And if there's a family history of cancer of the esophagus, stomach in the first degree, then those are all indications. So similar to what I just said about obesity, lifestyle changes work. You don't need 3 hours before you go to bed. You like to lose weight. So you avoid that triggers things that do tomato sauce and citrus fruits and things like that. You stop smoking, you avoid drinking. So those lifestyle changes work. You have to by a wedge and then you have weight. So there are lots of these lifestyle changes work. The next step is medical management. So medical management is your doctor gives you a medication and you take it and you feel better. The last step is surgical management. Just like the surgery we talked about obesity, there are surgeries that can help for fundoplication, that can help prevent acid reflux that have been available for many years. And more and more now, we have this option of the endoscopic management. So, PPIs. So we said the first lifestyle changes, everybody who has reflux, which try the lifestyle changes. Good lifestyle changes in weight loss, avoid smoking. Don't eat for 3 hours. If you do that first, then you'll need the medication. But many of you may have seen that PPIs, which is the class of this medication or proton pump inhibitor, they have been associated with some side effects that are now making it into mainstream media. So people are, when they come to me, they're like, I read that this can cause dementia. And what is wrong with dementia? We're scared I don't want to take this medication. Or kidney disease now, we're seeing more patients with the kidney doctor, they have slight problem with the kidney, and the kidney doctor wants them to stop this medication. They can predispose people to infections, hip fractures, because you need iron, you need calcium absorption for good bone health, you need acid for calcium absorption. So we suppress the acid. You can have normal fractures. So those are by far most people who take PPIs, this class of medication, do have these issues. But there is a small risk that these happen. So more and more people are concerned about staying with these medications forever. In addition, being on these medications for a very long time, patients who may have been on something like this for 20, 30, 40 years. And we see these patients, they have these polyps. So these are polyps in the stomach. Now, these polyps don't develop into cancer. They have a small risk of developing cancer. That's a known be on a PPI. So this TIF procedure is called Transoral Incisionless Fundoplication. It's something that we provide now at the University of Florida, and it works really good. So one of the patients today who came in for follow-up, she had a procedure in August. She had severe esophagitis because it's been and as a follow-up, they had the procedure. She had no esophagitis. She has no symptoms. She feels completely fine. She's very thirsty. So it's non-invasive, also done through the mouth. So again, I go stuff from the mouth. No incision. It's about 60 minutes, more like 45 minutes. Outpatient procedure. The common problem in patients who have surgery for this is something called gas flow. They feel bloated, but they cannot. This and surgery, it can happen up to 70% of patients. Without patients, it's easy to use. So it's very uncommon with that. So this is what the valve looks like before. And I think this is a video. No, it's not. It's just a picture. And this is what it looks like. This is the same patient. So you can see here that we don't have much of a valve. We'll have the nice to come up. And then after we did the procedure, you can see how it's nice and tight. And this will prevent things. Okay. So patients who want to be off of PPIs, who are not responding to these medications, are good patients to be on this. And thought there was a video about that. It's R&D questions. And here's my point.
Well,